image quality? Yeah, at this point, it's just an overview because we will go into this information in detail. It's really just so you have a little bit of an idea when you go to clinic and when you hear some of this verbiage being used, that you'll have some understanding of what's taking place. Okay. Right. So, what was the first image quality factor we talked about yesterday? And we finished it. What was first image quality factor? Contrast. Okay. Contrast. What does contrast mean? The difference in what?
Gray shades.
It's the gray shades, exactly. So it's a different in the gray shades. You may hear people say difference in grayscale. So whether you say grayscale or gray shades, either one is perfectly fine. But so it's a difference in the gray shades. So if you have an image that is described as having a long scale of contrast, what will that image look like? Long scale of contrast. What will the colors look like?
Black and white.
The opposite.
Oh, sorry. Yeah. More gray.
Yeah, more gray. So if it's long scale, that means we have numerous shades of gray. So another name for a long contrast image or long scale image would be a low contrast image. So remember low and long. So if it's low contrast or long scale, that means there are many shades of gray. If we have an image that is more of a black and white, then we refer to that as a high contrast image or a short scale, because we don't have as many shades of gray. And we have black at one end, white at the other end, and fewer shades of gray in the middle. So it's referred to as a short scale or a high contrast image. Typically, when it comes to extremities, what type of contrast do you think our extremity images have?
High contrast.
High contrast. And then larger structures, like femurs, T-spine, L-spine, abdomens,
Low.
hip. They're going to be more of a
Low.
It's going to be more of a low scale of contrast. Okay, and the reason for that is if you think of a large body part, like the abdomen, for example, and you remember we have high water content. So what type of attenuation is going to be a little more prevalent with larger body structures? What type of attenuation? Because remember, for attenuation, we have two things: Compton and photoelectric. So what's more likely with a larger body part?
Compton?
Yeah, Compton. Yeah, because of the high water content. Those outer shell electrons, very easy for them to be knocked out of orbit. So we get a lot more scatter generated with larger body parts than we do with extremities. With extremities, we don't get a whole lot of scatter being generated because we have more bone relative to soft tissue. But when you look at bigger body parts, then you start to get more soft tissue. So then the Compton becomes more prevalent. And, we said Compton, it adds an unwanted grayness to an image. Okay? So unwanted grayness. What is the primary controlling factor for contrast?
KVP?
It's KVP. It's the photon energy. Right, it's the photon energy. Because remember, and we had talked about this with interactions in matter, just generally speaking, as KVP goes up, we get more transmission. But if we compare interactions, as KVP goes up, which attenuation interaction is most likely to occur? KVP goes up, which interaction is most likely to occur? Photoelectric or Compton?
Compton.
Compton is more likely to occur as KVP goes up. Photoelectric starts to go down. So with larger body parts, another reason why they tend to be grayer is not only because are they larger, but we use higher KVPs with larger body parts. So that also lends itself to the generation of more scatter. So more scatter is produced with those larger body parts because we're also tend to use a higher KVP. Okay. So you have that basic, you think? You have to do some studying prior to Monday? Okay. All right, so another image quality factor is spatial resolution. And, we've talked about this just a little bit. And spatial resolution, it's known by a host of other names here, which you do need to be able to recognize. So spatial resolution, in terms of a formal definition, it's the ability to delineate between two adjacent structures. And in particular, it deals with, what is the smallest object that can be detected, that we can distinguish between. Well, when you look at this picture here, what is this showing you? I mean, what is this a picture of? You can tell what it's a picture of, can't you?
A butterfly wing.
Yeah, it's a butterfly wing, okay? So you can tell that with this picture and then this one here. But which one of these provides a little better spatial resolution? Which image is a little sharper?
Right.
The one on the right. Okay, the one on the right. We can still tell that this is a butterfly wing, but the image, the structural edges are a little blurrier. And when the edges of structures start to get blurry, then they blur right into the structure next to it. It's kind of like if you write something, and we've all done this, and you write something with an ink pen, and it doesn't dry, and your hand smudges it. Well, what happens to all of those letters, those nice sharp edges that you wrote? Can't they smear together? And we've all done that type of thing. So that's what spatial resolution is. Spatial resolution is how sharp are those structural edges. And you can tell when you look at this, you see how this part kind of blurs together, whereas over here we're better able to distinguish those black lines. So when it comes to, in particular, extremities, it's very critical that we have a high level of spatial resolution. Because when the radiologist looks at extremities, they're looking at the trabecular markings. There could be a hairline fracture in there. And if these lines start to blur together like this, then, that fracture will be hidden and that patient won't get an accurate diagnosis. So it's very critical to have image sharpness. And even on the flowers, it's a little harder to see the print here, but here you can better make out that print on that flower. So spatial resolution is extremely important. So spatial resolution, it's referred to as resolution, sharpness, detail, geometric unsharpness, image blur, geometric blur, and penumbra. So all of these terms are affiliated with spatial resolution. Okay. The last three, though, image blur, geometric blur, and penumbra, have to do with how much unsharpness is there. Okay, these deal with like how much sharpness. So if you hear the word penumbra, yeah, it's spatial resolution, but it's referring to exactly, how much unsharpness is on that image. And in the fall, you'll actually have another math formula. There'll be another calculation that pertains to spatial resolution. So you'll be calculating the amount of image blur or geometric blur or penumbra. So you'll be calculating that. So just be able to recognize all of these names as a part of spatial resolution. Okay. So as far as the categories, the factors that impact spatial resolution, they come under these headings here. There are things relative to the detector that impact sharpness, motion impact sharpness, and then we have a category referred to as geometric factors. So these are the three categories that will impact sharpness. So the first one to look at is the image detector, okay, the image detector. And this is greatly magnified, but for an example, you remember our flat panel detector that I showed you in lab? It's the one that stays in the battery charger in room 1. Okay. That device is all electronics. And if we were to peel off the cover of that, we would see individual boxes like this. Okay. Except they'd be very, very tiny. This is greatly magnified. There are actually like millions of these boxes in that detector. They're physical boxes, and that's referred to as pixel size. Now, when it comes to the phosphor plate, like when we take an image in lab, we're using the phosphor plate, that cassette that we have to stick in the reader. That phosphor cassette, that phosphor plate doesn't literally have boxes like this. We'll talk about when you use a PSP plate, how ultimately we end up with these things called pixels. We won't get into that right now because there's no need to get into that. But what I want you to understand, for right now, is that the pixel size, the dimension of these boxes that make up the image will determine the spatial resolution. Okay, so pixel size is going to play a role. So just as an example, which image do you like better? Or which one's clearer?
Left side.
This one?
Yes.
Okay. You can tell that this is a panda bear, but it's clearer here. How easy is it to see the details of this panda bear? Like, can you see the mouth in the picture on your right? No, you can't see the mouth. But here we can see the mouth. How about the toenails? Those claws? You can't see it. You can't see it, but here we can. Why are we able to see this image better than this one in terms of the detail? Based upon what I just said about the previous slide.
Pixels are smaller.
Pixels are smaller. Yep, the pixels are smaller. So the smaller the pixels, the better the resolution is going to be. Okay, the better the resolution is going to be. So right now, all you need to know is that when it comes to the image detector does play a role in the level of spatial resolution that an image will have. Okay, but we'll be talking a lot more about that, because we'll look at the different detectors and what impacts it. We'll look at CCD detectors, we'll look at CMOS detectors, we'll look at flat panel detectors, and we'll look at phosphor plate detectors. Okay, but for right now, just know pixel size plays a role. Okay. So if you're asked on a test, when it comes to detectors, what determines the level of spatial resolution? What would your answer be? Is everybody afraid to answer now? What, Gabby?
Pixel size?
Pixel size. Pixel size. Okay. The second category that impacts the amount of detail or sharpness is motion. Okay. What you're looking at here is a lateral T-spine. So that's a lateral thoracic spine, but it's blurry. It's blurry. Can you tell that it's blurry? It's fuzzy. You can see that it's a lateral T-spine, but these structures just kind of blur together. So what happened here is the patient moved. The patient moved during the X-ray exposure. The The other thing that could happen, but it is not nearly as likely, is that the equipment could end up moving during the exposure. That's really not an issue anymore because our equipment, it locks into place. You know, it's like electronic, it locks into place. With older equipment, especially with mobile units, you would have to lock it in place. There would be some type of handle or screw that you would have to tighten to hold that x-ray tube in place while it was directed at the patient. And if you didn't tighten that screw enough during the exposure, the x-ray tube would kind of fall down. So equipment motion is not very likely to happen. If the patient moves during an x-ray exposure, you have to repeat the image because the image will be too blurry. This image needs to be repeated. What is the best way to minimize patient motion? Oh, what a cute dog.
With the patient.
That's a cute dog, Casey.
Oh, yeah. He's being real needy this morning.
So what's the best way to minimize motion?
I guess communication with the patient about being still, and then immobilization techniques like sandbags and all that kind of stuff.
Right. The number one way is communication. That always makes, for a good question. The number one way to minimize patient motion is communicating with the patient. Don't assume that they know they need to hold still. They don't know when the x-ray exposure is over. Okay, so you have to let them know. Please hold still. I will let you know when you can move. And, there was one day when I had forgotten to tell that to a patient. You get so used to what you're doing and, in the habit of doing things, and you just kind of assume that everybody knows what you're doing. And so I had positioned a patient for a chest x-ray, and then I turn around and walk to go behind the control booth, and I turn around and the patient's right there next to me. So the patient had followed me right back into the control area. And it's because the patient didn't know that the exam had not even been done yet. So that was my fault. I had not communicated with the patient, told them they needed to remain still. And then if you can't communicate with the patient, then yes, like Casey said, immobilization devices. Do you use restraints? No. That has to be physician ordered. Okay. Then the next category that impacts spatial resolution is what we call geometric factors. The reason these things are classified as geometric factors is because they do impact the geometry of the beam. Because the x-ray beam, it doesn't come down in just a straight point. The x-ray beam diverges out. So these three things impact how that beam diverges, and therefore has an impact on the level of spatial resolution. So for geometric factors, we have focal spot size. You'll see it abbreviated as FSS. Sometimes I'll use that abbreviation on a test. Source to image distance, which is SID, and then object to image distance, which is OID. So I think, you already know your SID. That's from the distance from the actual focal spot down to the image receptor. The object to image distance is from the patient down to the image receptor. And then the focal spot size is what? What is that focal spot size? You all know by now.
That's on the anode.
Okay, the focal spot size, okay, what gives us that effective focal spot size, whether it's large or small? What will control that?
Filament.
The filament, Right. You know, the anode angle has an impact too, but we can't change our anode angle, but we can change our filament. So large filament versus small filament, because yes, that does, like you said, Whitney, that impacts the effective focal spot size. So the small filament, you get a small effective focal spot. The large filament, you get a larger effective focal spot. Okay. So as far as the geometric factors are concerned, oops. Let's just take a quick peek, because we'll be talking more about this. Which image do you like better of the hand? Which one is sharper? Left or right? Left. Yeah, the one on the left. The one on the left, we're better able to see trabecular markings, all of the fine bone lines, all those trabecular markings. They're blurred together over here. Even the joint spaces start to get blurred together in the carpal area. So this one is blurry. What could lead to this? Well, if you, for example, don't use the small focal spot, but you use the large focal spot, and maybe the source to image distance wasn't the right source to image distance. If you're supposed to use 40 inches, but you use 30 inches, that can cause unsharpness. And if the object to image distance is too great, then that can lead to unsharpness. Okay, so we'll talk in more detail about these as far as short SID versus long SID, and short OID versus long OID, and large and small focal spot. We will talk more about that. But for right now, what I want you to know, because of getting ready to go to clinic, is that focal spot size, SID, and OID will impact the amount of unsharpness. Okay? Will impact the amount of unsharpness that can occur. Okay? Now, one rule of thumb, though, I do expect you to know at this point, remember to always keep the OID as close as possible or as small as possible. Because the technologist will expect you to do that in clinic. Always keep that image receptor as close to the part as reasonably possible. Okay. All right. Okay. Distortion is some textbooks will talk about distortion in a separate chapter from spatial resolution, but distortion impacts spatial resolution, okay? And we'll be talking more about it, but distortion means that you have misrepresentation of an object. It's distorted. So it's not quite what it should be. Just like when sound gets distorted, sound can get distorted. So can objects, where they don't look like how they actually should be. So that's what distortion is. It's a misrepresentation of an object. And we have two types of distortion: size distortion and shape distortion. If we have size distortion, then that means something is magnified. It's larger than what it should be. Do you think that could be an issue? If you're imaging something and that part comes out larger than what it really is inside the patient, could that be a problem? You think that would be? For example, let's say you're doing a chest x-ray, and because you don't set the patient up properly, the heart is greatly magnified. Could that be an issue when the radiologist interprets that image? Yeah. How so? Now maybe that
diagnosis.
Pardon?
it could cause a misdiagnosis.
Yeah, absolutely, exactly. That patient may end up being diagnosed with cardiomegaly, and then they're being treated for something that they don't actually have. Okay, and this is how it occurs. We'll talk more about that. For purposes of your final exam, I'm not going to get into this, but if you're asked about distortion, know that it means there's a misrepresentation of the object. So, for example, the size could be inaccurate. The other thing that could be inaccurate would be the shape. And we've got something called foreshortening and elongation. We'll talk more about that. But basically, we end up with unequal magnification. So the shape gets distorted. The shape gets distorted. A structure can either look too long or it can look like it's scrunched together. It could look too short. That can cause problems, especially when there's a fracture. It may look like the fracture is spread further apart than what it is, or it may make the fracture look like it's closer together than it is, like it's healing better than it is. So you have to be very, very careful when you acquire images, because you don't want shape distortion and you don't want size distortion. We'll talk more about that. But for right now, if you were asked about distortion, know that size and shape distortion can occur. Size and shape are types of distortion that we have to be aware of. So would you be okay with that? And the size and shape distortion will impact the image sharpness. And we'll be talking more about that, but it will impact the sharpness of the image. I do have a couple of examples here, but like I said, I'm not going to have you worry about the specific details at this point. But here's an example of increased object to image distance. Here's the actual object. And if our image receptor is say way down here, look how that projected object looks. It's larger than what it actually is inside the patient's body. And it's because we've got a big gap between our image receptor and the part. Our image receptor should be up close here, just to show you. And this is just to prove to you that magnification does decrease spatial resolution. Can you tell that this foot is magnified compared to this one? See how large it looks? And it makes it hard to see trabecular markings. They just kind of blur together. It even makes it hard to see joint spaces. So that's what magnification will do. So I just wanted to show you, that size distortion. This is shape distortion. Here's an object, and then see how it's distorted. It should be more of an elliptical, but it comes out looking like a circle. Over here, it maintains the correct, basically the correct shape, so to speak, but look what it did to it. It stretched it out. And in both cases, there will be an impact on spatial resolution. Okay. So again, you don't need to worry. I'm not going to ask you about foreshortening and elongation at this point, but I did want to show you what it looks like. And we'll be talking more about that. Okay. We'll be talking more about it. And then here's an actual representation of it. This is the correct length of the bone. You see how it looks short here, and then here, how it's been elongated. And you will get a decrease in spatial resolution. So, here and here, there's a decrease in spatial resolution compared to here, for example. So can you see that it's harder to see those trabecular markings? Okay. So what two types of distortion can occur?
Size and shape.
Size and shape. Size means it's magnified, Shape means the part, it's either going to look long or it's going to look short. I'm not going to have you recognize the name foreshortening and elongation, even though that's pretty easy. But with shape distortion, just simply know a part can look long or a part can look short. But either way, size and shape distortion will end up decreasing that image sharpness. So you okay with the basics of spatial resolution? Okay. So what are the three categories that impact spatial resolution? The three factors, the three main categories.
Motion,
Motion,
Detector.
the detector.
Geometric factors.
Mm-hmm. Right, geometric factors. Exactly. So under the detector, we've got pixel size. Under motion, we've got the patient and the equipment. And under geometric factors, that's our focal spot size, our SID, and our OID. Okay. And then we have distortion, and distortion will impact spatial resolution. The size of the object and the shape of the object will have an impact on the spatial resolution. Okay. And then the last category is noise. Okay, it's noise. Noise is what we call extraneous information. It's interference. It's useless information. So when you look at the pictures over here, which one are you better able to see the word signal, the top or the bottom?
Top.
Top. I think everybody should pick top. If somebody picks down here, the signal, we can see that signal. The signal is the information, that's the useful information. When our image detector captures an image and then it releases the image data, the useful image data is our signal. And then if there's any unwanted information in there, then that's noise. That's extraneous information. And there's always going to be a certain level of noise with some of our images, okay? But we do our best to minimize that. Sometimes we can't completely get rid of it, but there are things we can do to minimize it. So what is the big deal about noise? The big deal about noise is that it will impact our visibility of spatial resolution. Okay, so it impacts our ability to see structural edges. It impacts the ability to see those structural edges. So that could interfere with us seeing anatomical structures or tubes or lines or lesions that are in the patient. The other thing that noise does is it will degrade contrast, and we'll be talking more about this. We'll be talking specifically about this next semester. But for right now, know that overall noise will degrade image quality. Okay, noise will degrade image quality. You do need to know the types of noise. The types of noise that we have are unwanted information, is quantum model and scatter. Okay, quantum model and scatter. These are two types of noise. So here are the examples. Both of these images have a certain amount of noise, unwanted, extraneous information. This one is a result of quantum model, or it's called quantum model. Okay, that's a noisy image. That's quantum model. Okay. This one, see how it's gray? It's got a pretty gray appearance there. Got a lot of scatter. That has really grayed out that image. Okay. But do you see with this image how it could be really hard to see structural lines? structural edges, because it's blotchy looking. What about if there's a tube in this patient? Could it be hard to fully see that tube? Yeah. So it's not a good image. Even over here, scatter really did degrade the contrast of this image, and it could hide things. It could hide lesions. There could be, an abdominal mass in here, and it could end up being very hard to see because of all this noise. Okay. So how can we minimize noise? Well, the way to minimize quantum model is using the proper mass, okay? Quantum model means that the image detector is photon starved. There were not enough photons to create the image. That's why you have that speckled appearance, okay? It's like having a puzzle, but having some of the pieces missing, okay? So the way to control quantum model is use the proper mass. You have to have the proper number of photons to create the image. Otherwise, that's what you end up with. Okay. And then ways to minimize scatter, and we'll be talking more about this, but ways to minimize scatter, one thing you can do is use the appropriate KVP. If you use too high of a KVP, then that will generate more scatter. Okay, because as KVP goes up, you get more Compton. Okay. Whenever feasible, collimate. Okay, collimate. If you're doing a lumbar spine, you don't need to have the image receptor open the full 35 centimeters, unless for some reason that's protocol at your facility. You can collimate in closer to the spine. That will help remove or prevent some of that scatter, because when you collimate, you're irradiating a lower volume of tissue. So you have less Compton interactions that will take place because you are limiting the amount of tissue that the x-rays are interacting with. Use a grid. So you will find it's protocol when you go to clinic. There are certain exams that you do tabletop, certain exams you have to put the image receptor in the bucky. Okay. Extremities you do tabletop. Why do you not need to use a grid for extremities? Think about the ratio of like bone to soft tissue with extremities.
There's less bone. There's less tissue, soft tissue.
Mm-hmm. Yeah, exactly. Good. Less soft tissue, but a lot of bone. Okay. So since we have more bone than we do soft tissue with our extremities, what attenuation interaction is more prevalent with the bone? Photoelectric or Compton?
Photoelectric.
Yep, exactly. Photoelectric. But then when you look at larger body parts, femurs, hips, abdomen, chest, spine, where do you put that image receptor? Where's that image receptor going to go?
Grid?
Pardon?
I said, it's gonna be the grid the grid?
So you put it in the bucky tray. That image receptor will go right under the table, right? Because the grid is there. Exactly, the grid is there because those large body parts, we've got a large, high percentage of water volume, a lot of soft tissue, with femurs and hips and spine and abdomen. So we get a lot of Compton being generated. So we need that grid to absorb that scatter radiation, okay, to help get, remove that scatter to prevent that, remove that grayness from the image. The other thing is to avoid overexposure. Now, mass, if your mass is too high, okay, mass does not cause scatter. What causes scatter is KVP. In other words, when we looked at interactions in matter, we looked at the factors that impact Compton and photoelectric. And remember, those factors were things like atomic number, mass density, part thickness, and photon energy. Okay, so let me be very clear here, make sure you understand this. Mass does not impact whether or not scatter occurs. Okay. What impacts whether or not scatter occurs are the atomic number, mass density, the part thickness, and the KVP. So how does mass come into play? Well, mass does impact the quantity of photons. So if your mass is too high, then you simply have more photons that are available to undergo the scatter interaction. Okay, mass has no impact on the probability of whether or not scatter occurs. Mass is just simply a quantity thing. So if the more photons you have, then the more photons you have that are there and can undergo the scattering process, undergo Compton interactions. So you have to make sure that you understand that. Okay? So if your mass is way too high, you do end up with more scatter being generated just because it's pure quantity. It's a quantity thing. There's just more available to be scattered. But mass has nothing to do with probability of scatter. It only impacts the quantity of scatter. Okay. All right. So